So we asked each of you to give us your thoughts on what a learning health system is. And what we've done here, actually, Jeannie and I did this after receiving your comments the last couple of days, is we identified sort of like a saturation grid. That's what this looks like. You know, how many people does it take to reach saturation? So we started with Stephanie. You can see the domains that she identified. And so with each new domain that was added, we added a row and we gave an X to people who commented on those domains. This is actually my interpretation of your input. It may not be perfect. I did my best to extract from what you said and put it into these domains. The domains also have attached to them a number, so it's the number of scholars who commented on that domain. And then I did highlight, it didn't, I think, get carried forward, but some of these domains I've actually highlighted as I think more important than others. So let's just go through this. You should recognize your initials up there because they're your first and last name initials. So 7 of you commented on that a learning health system conducts research, or other phrases that were used were evidence generation, knowledge generation. Some of you commented on the fact that informatics is a toolkit that's used. Most of you commented on the need to take knowledge and improve, embed that knowledge in the point of care. And it was different from implementation science. And I think you'll hear this over the course of the next year and a half, that the two are not exactly the same. A few of you commented very specifically on implementation science as a component of, at the bottom, as a component of the learning health system. Very commonly mentioned was stakeholder engagement, not just reaching out to stakeholders, health system leaders, clinicians, researchers, patients, parents, policymakers, but also using that engagement as a way to prioritize the kinds of questions that are addressed. Some of you, this is, I thought, very interesting. Some of you commented on a learning health system is one that is adaptable, that is able to respond to both challenges from within and challenges from outside, so-called externalities, and that like a complex adaptive system, health systems that are learning health systems also have that adaptability quality. Perhaps the most commonly mentioned construct was this notion of integration. Not just that research is done, not just that improvement is part of this, but that these two are integrated into a set of structures and processes that generate a learning cycle. And so the integration concept and the continuous or the cyclical learning processes, to me, are very similar, and they were very consistently commented on. One of you commented on the fact that, this is, I believe, Katie, that another piece here isn't just the knowledge generation, the knowledge application. It's also continuing to monitor the effects of the improvement. So having a monitoring system that's consistently assessing outcomes overall, as well as in response to changes, was, I think, a really interesting piece here. One comment on the hierarchical nature of a learning health system, that the learning health system need not just be like a hospital, but it can be a nation. In fact, I'm going to be going to Switzerland in 4 months. We've been planning a conference in Switzerland to create a Swiss pediatric learning health system. And Switzerland itself, as a nation, is adopting the learning health system model, connecting all of its hospital delivery systems to one another to improve and also to conduct research, which I think is very interesting. So you can think of a learning health system at that scale. You can think of it at the institutional scale, or perhaps a network of clinical care sites that work together to improve outcomes through knowledge generation and application. You can think of it at, so there's the macro level, you can think of it at the meso level. Some of you are working in service lines, like a cardiac care service line. Others of you are working in specific units. That's kind of the meso level. And a learning health system could be a primary care physician's office. It could be at that level as well. So there's this hierarchical nature, like all systems actually, that occurs or that can be observed in the learning health system. This next domain I think is very important, that the learning health system, this is a word that informaticians use the exhaust of clinical operations. That is, that it uses the routinely captured information that's part of clinical care, clinical operations, and then the financing of the health system. That learning health system needs to have a culture around continuous improvement, a culture around a commitment to improving the outcomes of people as well as the health systems themselves, and that culture should be aligned with the incentives, both the non-financial incentives and the financial incentives for getting better. I think it was Anita who talked about transparency, making the data transparent so that all in the system can see it and learn from it and contribute. I thought that was a very interesting comment. It's not a comment about the learning health system that's very frequently mentioned, but I think it is a key element here. And I think the third to last and in the penultimate, the focus on the outcomes, the co-production of outcomes by people, their clinicians, and their health system leaders. That's a key aspect of a learning health system. That it's not just about improving the processes of care. It's really about better health, relieving suffering, and better efficiency for health systems. And then finally, we mentioned the implementation science. So let me pause here. This I thought was excellent work. I believe that you've captured the key domains. I would say, if you had to say what are the most important, I would zero in on stakeholder engagement, number one. I think adaptability, a learning health system, because it's continuously learning, is able to adapt to challenges better than health systems that don't. I think that's number two. Number three, the notion of integration, which is linked to the cyclical learning process, is, I think, very important. Number four is using the exhaust, if you will, or using routinely collected data. And then I think five is the culture, having a culture of learning where incentives and people are aligned to generate better outcomes. And six is the focus on outcomes. So that's kind of the way I think about the conceptual framework of the learning health system. I'm going to show you a few slides in a sec that illustrate in a pictorial way how others, myself included, but other thinkers as well about the learning health system have conceptualized it. But let me pause and see if there are any questions or comments that people would like to make about the domain structure of the learning health system. If you want to make a comment, you're going to have to unmute yourself.
There's still a lot of parts to this. I mean, you know, 6 key elements to it, but I feel like it's really hard to completely distill into a succinct definition. Yeah, right. Into like a little pithy 10-word definition, right? And so that we're going to try to do that in a sec, because I think a definition is a bit different from the conceptual framework. Think about this as a conceptual framework. These domains, these are the concepts. The definition is the overarching concepts, and these are sort of the component concepts. If you were to measure, like, you could imagine actually taking the definition of a learning health system and its domain framework and developing operational measures of each of those domains, and then measuring the maturity. So maybe, you know, how far advanced are each of the health systems that are represented in PEDSnet towards the learning health system model? We could actually develop operational measures of that. So yes, there is a complexity here that is challenging. But if I'm talking to my mother, well, I don't want to get to the mother thing just yet. But let me see if there are any other questions or comments.
This is Erica. Can you all hear me? This is Erica.
You're echoing, Erica. You got one mic on.
Okay, I am echoing. Hold on, I'm going to try to figure this out. I'm not sure why I'm echoing.
You sound better now.
Okay, good. Well, I think it would really be helpful also to see an example or to read about an example of where this has been done well, because I think it all sounds so great, but it also sounds difficult to achieve. And so I know that would be helpful to me to really be able to read about, like, you know, this health system really epitomizes the concept of learning health system research.
Yeah. So. Echo from Mary said, please mute now. So that reminds me, Erica, of when I first started talking about the learning health system, it's about 10 years ago now. We started those discussions here at Children's Hospital Philadelphia, actually in the C-suite, in the office of the president. He had a group of people that met every week. I was part of that group. I was charged to develop, I kind of brought the concept of the learning health system to CHOP, say this I think would be forward thinking. This was 10 years ago. I would say our department chairs really couldn't get their minds around it. It was because it sounded like motherhood and apple pie, but like our surgeon in chief said, Chris, I'm a surgeon. I cut through the skin, then through the fat, into the fascia. I do things step by step. Can you give me a specific example of, you know, how you would go from point A to a fully functional learning health system? And that led us to conclude that we were probably ahead of our time for an institution to take on the learning health system concept. I think that's not the case anymore. I think I've visited in the range of about 60 to 70 pediatric institutions over my career. Many in the last couple of years, and everywhere I go now in the last maybe even 3 or 4 years, the learning health system model is discussed throughout the organization. So it's really starting to permeate healthcare institutions. With that said, I don't think that there's a common agreement on what it is, and I don't know that I can point you to a specific healthcare delivery system that does it at the most mature level. And that's the challenge here is us as health professionals interested in the learning health system, how do we help our organizations and ultimately other organizations that provide care to children become more of a learning health system. We will share, Ingrid, maybe you can make a note of this, a paper, we'll send it out after this meeting today, paper by a couple papers from the old Group Health Cooperative, now Kaiser Permanente in Washington, in which the learning health system discussion started with a guy named Eric Larson, who was the chief research officer at Group Health, then Group Health in Seattle, which is a staff model HMO, and Sarah Green and Rob Reed, and the three of them brought the concept to the leadership. It was actually the board of directors, which has a majority composition of consumers, so more than half of the members of the board are patients there, and that's what they bring. They bring their experience to the table. And it was that board that said, we believe that the most important priority for us is whether our new primary care medical home initiative is effective. So they reached out, they got all this input, and ultimately it was the board that brought that question to them, and they did some analyses on that. So what I'll do is I'll share and did some analyses, and they did an improvement project, and they evaluated the effects, and they published the effects. But where I think the group health model is a little bit limited is that we haven't seen them continue to do that kind of cycling across the organization. So I believe there's still a lot of work to be done among health systems. We'll share those two papers, and Don and I and others have talked about possibly doing some case studies that you can evaluate to start to make this a little bit more concrete. So that's a good question. Other thoughts?
This is Anita, and I'm not sure if my mic is the culprit, so let me know if it is.
Sound good.
Okay. So one question I had, or one scope I think would be helpful, is identifying, when we talk about learning health systems, are we talking about institutional specific, organizational specific, or as you mentioned, you're going to Sweden to talk about like on the national level. So I think understanding what scope, or could it be any of those? And if so, how does that change how we define the learning health system? Because I think we're all, at pediatric institutions, and could we have one network, a larger network of learning health systems across our nation, and be more proactive about how we coordinate certain, multi-site trials or learning, understanding that there's going to be individual contexts across all of those levels. So I'm not sure if most of us have come with the interpretation this is sitting at our own institutions, but how does that layer on to some of the legislation or policies that come down from the national level?
That's a great question. I got the echo again, so let's make sure we mute the mic. So one of the system property, a system property, is that virtually all systems, for sure, all complex systems. So a simple system will be like a pulley system, right? But a complex system has a lot of interacting parts. Is that it's hierarchical, that there are multiple levels. So a very mature institution that is pursuing the learning health system model will embed the learning culture at all levels, at the micro level, at the the nurse, the physician, the patient, and the parent. That level, that bedside level, to the meso level, to like a cardiac center level, to the institutional level. And so we're talking about all of those levels. Not only are we talking about all of those levels, but we're talking about any system that is designed to produce better health for individuals or populations. It doesn't have to be a hospital. It could be a community primary care clinic. It could be a public health provider. It could be a community that is organized as a community to produce services, not necessarily just healthcare services, but a variety of services that promote health and well-being. If you're interested in the community approach, in Santa Monica, California, the Santa Monica Wellbeing Project, and you can Google it and you can check out their metrics, is a project that the city itself, Los Angeles is the city of cities, has undertaken to define what it means to achieve a state of well-being. A lot of that definition relates to health, and then it's now investing in different parts of the various service sectors to promote well-being. And so they have a dashboard that's made public. You can see it on the website. It is created, the metrics themselves and the priorities are created with very engaged stakeholders from all parts of the community. And then the social services, the Justice Department, the healthcare organizations, et cetera, are brought to the table to figure out ways to promote well-being. So I bring that up because sometimes, because we work in hospitals, we think of the hospital system as the learning health system unit. But when we developed, like with the Learning Health System Researcher Competency Project, some of the input we got when we sent that report out fairly broadly across the country was, let's be sure that we don't so narrowly define the learning health system that people view it as a healthcare institution or a healthcare hospital, or a hospital as a healthcare organization. It should be any entity that's designed to promote health in the population or among individuals. All right, let's go to the next question. Go ahead.
Sorry, I was just going to ask one other question, which is whether you would consider something, this like a binary thing, like either you are or you aren't a learning health system, or could an organization be on some spectrum of, incorporating some facets of the learning health system, but maybe not others? And if so, at what point is something defined as a learning health system versus not? Or would you say this is more of a spectrum of, do you know what I'm saying? Maybe I'm not articulating myself well.
Yeah, no, that's a great question. Go back to the prior slide. So here we were articulating the conceptual framework. And, one of my areas of methodological expertise is in measurement. And so I would say from a measurement perspective, the learning health system is a multidimensional concept. So it's multiple pieces, right? So we went over the multiple pieces. I would think of a learning health system as having a maturity, take it like a pediatric developmental perspective. So you may see one health system that's highly mature on a couple of the domains, say on quality improvement, but less mature on research. That doesn't mean that it's not a learning health system. I think the fundamental attribute of a learning health system is that a community of people are organized to promote or to improve outcomes. A community of people are organized to improve outcomes. By outcomes, I'm really talking about health outcomes, to be more specific. And yeah, a healthcare institution is just really it's a social construct. There's some bricks and mortars, but it's really a social construct. It's a way of organizing people. And then there are a number of tools that get brought to the table in order for that community to be effective in improving outcomes. And learning is sort of the set of processes that's used. So there are quality improvement tools, there's implementation science tools, there's informatics tools, there are research tools. And each of those tools in your toolkit are brought depending on the phase or the problem. So if I were going about measuring the learning health system, I would create, say, almost like an ordinal scale across each one of the dimensions. So take integration of discovery and application. You could think about that as not happening at all, happening a little bit, a moderate amount, or fully mature. And so I would say if the system is organized, it's deliberately designed, in which case there's some organizational piece to this and there's a financing piece to this, to improve patient outcomes, it is a learning health system. Now, whether it's learning well or not is a matter of degree. It's a matter of maturation. Okay, let's go to the next slide. That's great. It's a good discussion. And as you may recognize, I'm not going to say this is the learning health system conceptual framework. I think that's something that's work that needs to be done. I don't think that paper has really been published. There have been reviews of learning health system conceptual frameworks. In that learning health system research competency paper, we reviewed some of those reviews, but I still think there's more work to be done. You're all learning health system researchers, scholars. So you need to be able to say in your own words, whether it's your CEO or it's your mother or father, what a learning health system is. In reading through all of your comments, I came across one that I thought was pretty good. So Suchitra, it was yours. I'm going to ask you to, actually, rather than me reading it, maybe I'll just put you on the spot and ask, you bump into your CEO who you know only vaguely, and your CEO says, what's going on? You say, well, I'm in this new program, this PEDSnet Scholars Program. It's focused on learning health systems research. And she says, well, what is the learning health system? Are we one? And how do you answer that? Is Suchitra on the line?
I am, yes.
Yeah.
I'm sorry. Can you all hear me?
Yeah, I can hear you.
Okay, perfect. Yeah, so I was actually thinking that I needed to be prepared to come up with this kind of answer to this type of question. So what I had put together was just thinking of it from that terms of it being a transformation of the way that the health system traditionally operates, where it needs to be something that's coordinated, and it's really a system-based model where every day there's health information and there's care delivery, but there's a way that we could learn from what is inputted into that care delivery that you could then use to continually improve that process. And like you mentioned, the different things in your toolkit, the things that I think of would be sort of science, traditional research, and informatics, but then also integrating improvement processes and implementation science efforts, and then this culture based knowledge to then align all these things to be able to help with that continuous improvement and innovation. So the stakeholder engagement is really key. So we need to engage end users like patients and families and providers and CEOs and sort of higher ups. We need to make sure that we know what type of knowledge to capture and come up with good metrics and frameworks for that. And know that this is going to be something iterative, that you gather this knowledge and that you build on it over time.
So that was a very scholarly answer. I liked it. I think that you have hit on a lot of the points, but you've got like 10 seconds to actually say what it is. And so, you're gonna be asked this question a lot. All of you will be asked this question a lot. And so, on the one hand, you want to have a deep knowledge of the different domains of what a learning health system looks like. You want to have a vision of what it can be in the future. But how do you explain it to a COO or a CEO, and in a short, pithy way? Like, give me your 10-second answer.
Back to me?
Yeah.
Okay. So short, pithy answer is I think of it as a system where, let me just think about starting over. So you have a integrated health system where you take the knowledge from that health system based on feedback from stakeholders, and then you try and provide an answer to a question that you may have in clinical care to help to help with those outcomes. I can think of it on an example level. It's very hard to describe in a 10-second short and sharp way.
Yeah, it's hard, isn't it?
Yeah, it is.
But let me ask you this one last question: is Children's Hospital Colorado? That's where you're based, right? Is Children's Hospital Colorado a learning health system?
I would say it is. Yes.
Yes. And what does Children's Hospital Colorado need to do to be a better learning health system?
So just thinking about the different elements and different domains, I think one thing that we may need to improve upon is the way that we determine what the focus needs to be, and are we making sure that all of our key players are involved in some of those decisions? So have we engaged all the appropriate stakeholders? I think that's one area that we can improve on.
Yeah, I think that's great. And I would say, like, at Children's Hospital Colorado, like all of our institutions, you've got research over here, and the incentives around research over there are around investigators building independent research programs. They, in 21st century, there's a lot of collaboration, but it's largely on questions that the researchers find to be important or funders find to be important. And then over here, you've got clinical operations. And the two don't really talk to one another. So research and development on one side of the house, clinical operations on the other side of the house. And clinical operations includes your extensive quality improvement programs that are part of Children's Hospital Colorado. You've got this electronic health record system that sits here, and every now and then the research arm dives into the electronic health record. So what I would suggest is we think about how to define a learning health system to people who are not thinking about this concept every day or every minute of the day, is that it's a health system that learns from every patient, uses our electronic health record data to learn from every patient, and better integrates research with improvement, so that both the research that's done and the improvement that's done is brought together around improving outcomes, so that there's more integration between research and improvement. So if you had projects at Colorado Children's where the project was of high value to the institution strategy, like the institution wants to take on population health and wants to embark on a care management program, and it doesn't really know which of 2 or 3 models is the right model, and then Suchitra is asked to do an evaluation. As a couple of models are being rolled out, you're evaluating along the way. You're generating new knowledge that's going to be It's important that it's contextualized for Colorado. You're going to be feeding that back. You're using the tools of research to do the study. You're allowing clinical operations to unfold as it would naturally, but there's this research piece on top of it. And then whenever you determine what sort of the best approach is, you start to monitor the outcomes going forward. Then I would say you're in a learning health system model. So that notion of better integration, which you guys came up with as one of your domains, I think is key. I often talk about research and improvement are conventionally siloed. The learning health system brings them together in order to improve outcomes of kids as well as health systems. All right, I want to just share with you now. That's great. Thanks for all this discussion. Let's go to the next slide. So one of the domains of being a learning health system researcher is to approach problems with systems thinking. And there's a lot out there around living systems, complex adaptive systems, complexity theory, as well as system science. There's no shortage of readings, and we're going to be sharing with you a set of readings. And if this is an area that's of interest to you, part of that list will focus on what I think are because it's an area I spent a lot of time thinking about, high value readings. I don't think we're going to devote specific webinars to system science. We're going to try to embed it in everything that we do. But I thought it'd be useful for us to touch on some of the key principles of system sciences. It gives you a sense of how you think about the learning health system differently from just a healthcare organization. So the sort of the classic work on systems theory is cited here. It's from 1968. Ludwig von Bertalanffy was a biologist who wrote this book called General Systems Theory, and that spawned all sorts of additional, in many fields, works on using systems theory to better understand some of the complex problems in science. That's von Bertalanffy's definition. A system is a set of elements standing in interrelation. You'll see that with more modern ways of thinking about systems, complex adaptive systems. The word agent is often replaces the word element, and standing in interrelation gets replaced with agents interacting with themselves and with the environment. Chemical systems can be closed. They can like a test tube, but virtually no system that we're interested in, certainly no living system, is closed. They're all open, which means that the living system, whether it's a human, it's a cell, or it's an organization like a learning health system, is in continuous interaction with its environment. And that means that there are inflows of information and then there are outflows, and that the system itself is never stable. It's constantly changing. So the question from a learning health systems perspective is, can we learn from the change? Can we learn from our experiences? Can we learn from every individual who's part of that system? And then from those learning, gain experience, gain wisdom that we can then apply to become more adaptable and to grow and become better. Go to the next slide. Here I called from literally, I'm not going to go through all of this in detail because it kind of gets a little dry, but from all of my readings, I went through this the past few days, all the different properties that you might ascribe to a learning system. So composed of agents that interact. Think about that as a network. Think about the nodes as agents all interacting. Some nodes of the system interact with more parts than others, but they all interact to some degree. We talked about the system can be hierarchical. We live in a world that's very complex, and that's certainly the case for learning health systems, that they're not simple. They're not like the police system. There are a lot of moving parts. And because of that complexity and the hierarchical nature, phenomena that you might see at one level, like phenomena you may see at the institutional level, result from all the interactions at the meso level or in the healthcare system perspective. The institutional outcomes are a result of complex nonlinear interactions between all the parts. The famous quotation that a system is designed to produce all systems produce the outcomes that they are designed for. So if the system is producing poor outcomes, it's not the system's fault. That's the way it was designed. That's the way it's organized, and that's the way it's being operated. So then the challenge is how to rethink the system design. But what I wanted to mention is that a complex system that's adaptive, or what's we call the complex adaptive system, has the ability to learn. And one of the great advances of living systems is that they learn from their environment. Even E. coli can learn from their environments. Without getting too much into genetics and epigenetics, suffice it to say that from the cellular level all the way up to the organizational society level, living systems are constantly learning. Now there's both good learning and then there's more limited learning. But learning generates intelligence. As we begin to take advantage of our experiences and we bed that in our memory, we can then bring forth that intelligence to accomplish our goals. So learning is all about being able to achieve goals. And in the health systems context, we're trying to improve health, reduce the suffering of people, and maintain their health, and enable them to pursue the goals in life that they feel are valuable. But what's important to bear in mind is that we live in a world where we're like an open canoe going down the rapids. There is constant whitewater. Things are constantly shifting. This has been called, we live in a wicked learning environment. It is not easy to learn in a rapidly changing environment. Because we live in a wicked environment where there's constant whitewater, we need new approaches to learning. And that's what excites me, is that can we think about how to create systems that care for people, reducing their suffering, improving their health, enabling them to achieve the lives that they think are valuable, to achieve levels of well-being. And if so, what does that mean? What does that mean in terms of our informatics tools, in terms of our social tools to bring communities together, organized around a common purpose, our improvement, implementation, and research tools? That's the challenge. It's not simple. When we started our conversation on what are the domains, this is not simple. Let's go to the next slide. Bear in mind that the health services system has a financing piece, has an organization piece, has a population that interacts. That's Kerr White. If you haven't read Kerr White's paper on the ecology of medical care in the New England Journal of Medicine, now published 40, 60 years ago, it's not outdated, and you should take a look at it. It basically articulates that in the community in a given month, 750 people will have a symptom, but only 1 in 3 will actually. Gives you a sense that yeah, there's a lot of healthcare going on in the hospital setting. It's only a small subset of people actually receiving care. With care, health dimension. Is the health system producing better health? And is it producing better health within a constrained budget? Because there's never unlimited resources. The next slide gives you a sense of how I think about the opportunity to create a learning health system in a clinical context. This is not a population context. This is, in other words, not a public health context. But on the left, people come together, people and their families and clinicians, they come together in some organization. It could be at home, it could be in a primary care clinic, it could be a hospital. And at that point of care, that's where the learning occurs. So the mantra of learn from every patient in the learning health system, that really is saying let's digitize the data that we can at the point of care, capturing changes in health, characteristics and context of people, as well as their outcomes. And then to the right of that are essentially improvement or knowledge implementation activities where we can standardize processes. Let's do that. Let's knock out unnecessary variability. And then let's measure patients' needs and customize care, personalize it, in other words, to patients' specific needs. And then we generate outcomes. So we generate outcomes from the point of care, and the point of care may have improvement wrapped around it. And we constantly are monitoring those outcomes. That was something that Katie talked about in her domain assessment, that we should be constantly monitoring those outcomes. This could be in a critical care unit, or it could be in an institution. And we identify the gaps. Where are the knowledge gaps? Where are the areas of clinical uncertainty? Where would research, now you get to identify uncertain management practices, where would research actually be able to add new knowledge that would enable us to use improvement in order to improve outcomes? So this is, if you look here, we've got improvement up on the right, we've got research in the lower left, and we've got the capture of the encounters data down below, either in just electronic health records, or you can even create registries and applications that's on top of the registries that are constantly mining the registries to identify improvement opportunities. Let's go to the next slide. This is just another illustration I've used in a grant. Sometimes I talk about the research piece as the afferent arm from the point of care to the knowledge network. By knowledge network, I mean sort of the totality of knowledge that's been generated by research and that sits in the biomedical research knowledge network. It's searchable by PsycInfo or Medline. And then the application and the scaling of that is improvement and implementation. Let's go to the next slide. If you want to have a kind of ready single sentence definition, the best one I've seen, a learning health system is a health system at any scale, so that's a different level, that can continuously and routinely study and improve themselves. So if we were looking around at all the health systems out there, if you apply this lens, and then you look at the health system, you apply this lens, and then you answer this question, that tells you how well the health system may be operating as a learning health system. Next slide is some of the key elements of the learning health system that we touched on already. Let's go to the next slide. I wanted to show you how a informatician thinks about a learning health system. This is Chuck Friedman's work. This slide and the next one that he's allowed me to share. So Chuck is he's a national leader in informatics. He's based at the University of Michigan. He was the director of the Office of the National Coordinator when it first was launched, and is involved in the kind of the national scaling of electronic health records. He got very turned on by the learning health system concept. He talks about a national learning health system that's a cyber-social system that integrates the computers and what computers do well with what humans do well in order to produce better outcomes. So here, the way he set this up is that this is a learning health system organized around the common purpose of reducing falls in nursing homes. So I circled the formation of a learning community because the first step in the learning health system model is to form a community of engaged people. You often start with just a few, and then those few people become the guiding coalition that then spreads and recruits other people around a purpose, not around money, not around a contract, to get something done, but around a purpose. In this case, it's to keep elders from falling. The first step, the next step after the social, I think the first step is really social, is to collect data. How many falls are there? What's the epidemiology of falls? And then what are the best practices? So this is where research comes in. Start to use routinely collected data, and he called it data to knowledge, and generate new knowledge about what are the best practices. And then knowledge to performance. Based on that new knowledge, develop a set of recommendations, perhaps a new set of improvement activities. Take action, start to implement through quality improvement. That's the kind of efferent arm, and then continuous, and then monitor. And as you see whether or not things are working, you make course corrections. And so it's a cycle, it's a circle, right? You're continuously monitoring, making changes, evaluating, generating new knowledges, interpreting, and bringing it back to the point of care. What it's not, I like this next slide a lot, go to the next slide, it's not this. It's not just study and then publish. Because if you do that, the chances of there actually being any impact on people's health, which is why we're in this field, is very, very limited. There's no shortage of evidence that shows how ineffective publications are in achieving change. I'm not saying don't publish your results. What I'm saying is that a learning health system research project is one that generates new knowledge and has embedded in its design the application of that back to the point of care. We are going to share these slides with you. I just wanted to, I didn't want to prompt you too much for the early discussion. Let me pause here, see if there are any questions or comments on these figures or these slides that I showed on the pictorial representation of the learning health system.
I love that graphic interpretation of what a learning health system is. Ironically, that last slide is really what we're asked to do many times, and it's why I'm so excited about learning how to be a learning health system scholar, to really marry the continuous improvement process with the research aspect as well.
Who was that talking?
That was Melissa.
Melissa?
Sorry, my webcam
Okay,
isn't.
great. Oh, that's right. Yeah, so Melissa, and for others, what's going to distinguish you from your colleagues down the hall? Your colleagues down the hall have been trained to do what's on the left, like the blue line. That's research training. What we want you to be able to do is then take that result and bring it back to the health system, to bring it back to the point of care. And another piece that it's not in Chuck's diagram, but another piece that's important is that if you are highly engaged with your stakeholder community, that community is the receptor, if you will, the receptor organ of the knowledge, right? So it's not just a matter of asking people what they think is important. Call the priorities from your stakeholders. Keep them involved through the conduct, interpretation of the results, and then they become natural. That's the natural avenue for uptake. So what will distinguish you from your colleague down the hall is that you do blue and red, and most researchers are only doing blue. In fact, it may be a misnomer to call what you all are becoming learning health system researchers. I would say that there's some phrase that's better than that. I don't actually know what it is yet. Maybe we'll invent it. A learning health system. I hate to use the word specialist because you're not, but that's the word that might make sense in medicine. But you really are going to be generalists with specialized expertise, if you will, if I can say that, around how to improve outcomes through the tools of learning. Okay, other questions, other comments?
I think this is Erica. What stuck out to me in reading and the assignments is how much work has to be done up front in the preparation phase of how the research is going to feed back into improve care and value and outcomes. And I think in the traditional model of research, that's just not the case. And so, the end goal is, of course, the journal publication. If you go a step further, it's dissemination back to the community. But then it does tend to stop there. And I think in order to be successful at taking it further, you have to have a plan from the start as to how that's going to feed back. So that was one of the things that stuck out to me, is just how much time it likely will take to prepare for this type of work.
Yeah, I agree. I agree. 80% of this work is going to be 80% of the impact, if I can say that, impact of this work will be in the just choosing the right question. And choosing the right question means it's got to be of value to people, and choosing the right question means that it's going to be feasible and that you can do it in busy routine care settings. So doing that upfront work is critical. Getting people engaged is critical, but then also deliberately designing not only the research but also the implementation of that research is also important. We just got notified today that a study that we submitted to PEDSnet was funded by PCORI, The lead investigator is Greg Tajan. He's a pediatric urologist. And I believe it's a classic learning health system study. We helped him design it, but he's been a motive force behind this. In urology, there are 3 procedures that can be used to remove kidney stone. Kidney stone, I didn't know until I started working with him, but there's an epidemic of kidney stones. It's been increasing at a rate that's faster than the rate of obesity. That shows you how quickly it's been increasing in adolescence. You can remove the stones by surgery, through endoscopy, up through the bladder, or you can remove them through lithotripsy, ultrasound. There's never been a study to evaluate which of those procedures is best for whom. So what he's going to do is allow clinicians across multiple institutions to determine with families which of the 3 procedures to pursue. It's not going to be randomized. It's a quasi-experimental design. We then standardize the outcome, a combination of stone clearance through ultrasound, that's going to be done in a standardized way, as well as patient-reported outcomes, people's experiences of their pain and other kinds of measures of suffering. And then at the end of the observation period, we'll have results. But the results will then be reviewed by families, clinicians, and patients. And then we'll bring those results back, we'll generate from those from that work sort of guidelines that then will be implemented back into the point of care across all of these centers, and we'll continue to measure the outcomes of stone removal and see how practice change and see how outcomes change. So I think that's very exciting. So if you could, it's been funded, but B, to start thinking about projects like that where it doesn't have to be a classic randomized controlled trial. There are many other designs that can be used, and funders will fund it. And then also bringing it back to the community, I think, is of great interest.
Yeah, hi, Chris, this is Don. Can I make a quick comment?
Please.
So a couple of things. First, you'll know a non-learning health system when you see it, and I still remember the time that the Joint Commission was visiting Boston Children's, and the teams were all presenting all their great work, and then I think it was the neurosurgery team presented this unbelievable transformative study they published in the New England Journal, and the surveyor, who, as you know, are often maligned for just doing check boxes, said, "So can you show me where you do that at Boston Children's Hospital?" And the answer was, "Well, we haven't really done it here yet." And the same thing is sort of true of some of the research, and pardon to my colleagues, on the handover work that was done at Children's, where it's become national. There's a spin-off to get everybody to use it, and yet at Boston Children's it hasn't become standard work throughout the institution. So keep asking yourself, what would it be like to actually apply the results of what I'm doing in my own organization, let alone somebody else's? The other comment is, and I haven't solved this, there's a constant struggle between power, statistical power, and rigor, and trading it off against usability and practicality for the organization that you're trying to learn and implement in. And I haven't solved that, but it ain't easy, and no excuses. It's just really hard to get that right, especially in a training program that doesn't go on for forever. So that's where I think your mentors and project teams will be helpful in guiding you to the right balance between having it rigorous enough that it will be credible, that you can actually attribute what you're concluding to what you did, while at the same time getting it implemented and tested in your organization.
Thanks, Don. Those are terrific points, and I wish we had more time for the discussion. But thanks for your engagement, everybody. As you know, we did not get to the competencies, but a la the Amazon approach, we asked you to look at it, and I hope that that was useful for you. We will be visiting those competencies as we go along. Have a terrific rest of August and a great Labor Day, and we'll be chatting in September. I'll be in touch by email between now and then. Take care.
Thank you.
Thank you. Bye-bye.
Thank you. Thank you.